Welcome, everybody, to the inaugural Critical Care BC podcast. I'm Adam Thomas. I'll be your host today. And I'm met with an awesome crew. And today we're going to be talking about all things sedation practices in critical care. So, kind of left to right, Fiona Howarth, she's our clinical nurse specialist in Fraser. Next up, we've got Dr. Anish Mitra. He's one of our staff ICU physicians at Surrey Memorial. Then we have Sybil Hoyce. She is all things critical care BC and has extensive history as a critical care bedside nurse. Then we got Jason Zerba, our respiratory therapist educator in all things Guru Vent. And then last up, we got Dr. Hussein Kanji, ICU physician at Vancouver General and critical care BC executive lead. All right, everybody, thanks for joining us today. We're going to talk about sedation practices in our critically ill patients. I think we can all agree a little bit controversial, a little bit nuanced, and the literature's all over the place. So the hope today is that we can contextualize it for BC. So today we'll talk about how we've shifted away from deep sedation over the last 20 years to a more patient-specific, goal-directed approach. And then we'll break down those nuances for specific patient populations and then actually just how to apply it to your patient at the bedside. So let's get it started. Huss, what are those things that I need to care about for sedation and why does it impact our patients so much?
Yeah, thanks, Adam. Really excited to delve into this conversation and hear from my peeps on what's sort of happening around and what's actually important. I think particularly with regards to sedation, we've known for a long time that obviously sedating and overly sedating patients is a bad thing. When you look at the SCCM, PADIS guidelines, we know that oversedation, leads to greater ventilatory free days, or I guess fewer, increased mortality and delirium and increased stays in the hospital. We've had evidence in the past, I think, that's really related to how do we achieve that. So I know we're going to delve into the spontaneous awakening trials, but I think that's set up the stage depending on where you work. And I can speak just specifically to our experience. We've really moved to more targeted sedation within our ICU. So what does that mean? Really just looking at, I think, a RAS goal and really targeting the sedation and the practices accordingly. And again, I think the conversation will be amazing to see how people achieve that and what the direction is now.
So I guess that begs the question is, how did we get here? So we had decades worth of deep sedation, not the light sedation based on a RAS score like Huss just referred to. And what that says is really we should be aiming someone who's awake, comfortable, and directable, and not someone who's GCS chair and can't move in the bed, right? We know when they're deeply sedated, they have longer bouts of delirium, longer cases of weakness, and therefore their ICU and hospital stay are longer. Anish, how do we build up what Huss just said, kind of targeting the SCCM PADIS guidelines of breaking things down in RAS score, analgesia, and delirium? What's your take on that?
Yeah, that's a good question. I think as a piece just to add on to talking about deep sedation versus light sedation, I think in modernizing practice, what we're seeing is a focus on lighter sedation during the day, but sometimes we don't always see that at night. And there's this idea that, oh, I need my patient to sleep, so let's RAS -5 them, and then they can get a good night's sleep. And I think it's important to just mention that piece as well, because while it looks like they're sleeping, we have good evidence now to show, based on EEG studies, to show that it's not true restorative sleep, right? It's not the same sleep structure you get when you're actually sleeping. You've just made the patient comatose, and you're probably not helping them. And in fact, maybe causing some of that harm from deep sedation that we saw when we were deeply sedating all patients, right? But you bring up a good question. When we talk about sedation, sometimes we lump in agitation or anxiety and pain into one thing and say, okay, what agent can I give to make the patient's symptoms go away? But really, they should be considered two discrete elements, right? And this is where if you can focus on analgesia first and make sure you're treating any pain that the patient may be having, then you have an opportunity to reduce the amount of overall sedation they need. Now, it would be great if our patients could always just tell us that they're in pain and communicate how badly they're in pain, which they sometimes can, and we should always use that first if that's an option, but many of our patients can't. And so that's where we have to use validated objective scoring tools like the BPS or CPOT, which is what we use in my center, to help titrate those analgesic agents first before we start up titrating our sedating agents, in order to try to provide the minimum amount of medication in order to achieve the RAS goal that we are hoping for.
Man, so many good pearls in there. So we're saying is that our patients aren't just benefited by sedation. Pain is not better with propofol or midazolam boluses. Delirium driven by GABA specific tone is just going to be worse, meaning more benzos, more delirium, more benzos, more delirium. So really, Anish, you're saying we got to break it down into those components. I got to treat analgesia. I got to treat agitation. I got to treat delirium. I like it. And then, Jason, if they're not delirious, they're following commands. How does that benefit you?
Well, thanks, Adam. The vent lit is pretty ambiguous on a lot of things, but what it's not ambiguous about is spontaneous breathing trials and how important they are. And I can do a spontaneous breathing trial if somebody is lightly sedated. I can't if they're deeply sedated because they're probably not breathing. So the lit's also pretty clear that the deeper you sedate somebody, the more asynchrony you're going to have on a vent, and the more diaphragmatic atrophy you're going to get. You're going to have longer vent times. There's also emerging research talking about the power that you ventilate a patient's lung with and how that can contribute to ventilator-induced lung injury. So if a patient is lightly sedated, they can breathe spontaneously, I can use less power and potentially cause less ventilator damage. If there's better distribution of ventilation, there is less diaphragmatic atrophy, there is all kinds of good things that happen when a patient spontaneously breathes because their sedation is lighter.
Nice, Jason. So what you're saying is instead of getting punched by Mike Tyson with every breath, if you get punched by Manny Pacquiao, it doesn't hurt as much. Okay, I like.
Exactly. And I mean, there's the patients that you have to deeply sedate. If they are not synchronous to the ventilator because they're fighting it, well, then you're gonna have to bring Mike Tyson around to give him a good body blow and one to the head. But if you can ventilate them with a lighter sedation and let them do their own thing, they're going to be a lot better off.
Nice. So before we move on to choosing the right agent, then, just to summarize, guys, is that if your patient is comatose, you think they're resting, but it turns out your glial lymphatics aren't going to clear out all those toxins, your delirium's not going to get better, you're going to prolong things. And then while they're deeply sedated, they're dysynchronous, their diaphragm's getting weaker, their whole body's getting weaker. We're not helping them at all, as long as they're not in the critical throes of illness that they need deep sedation. Before we move on to choosing the right sedative, anybody want to add anything there? Any anecdotes? Any thoughtful tips?
I just want to second what Anish said. I mean, I love the approach of being deliberate, right? Really looking at what we're treating with the pain, the agitation, and the delirium, and using targeted scores to do that. I'll put in a plug for your future podcast now. How do we help patients sleep? I think that's so important. And I really appreciate, Anish, you bringing that up because sleep is not sedation. So I think that was a great point.
Coma is not good for brain. Got it.
And I'd echo that about how we modify our environments to promote sleep versus relying on drugs.
Yeah, exactly.
What, Fiona, your circadian rhythm works when someone's shining lights in your eyes every minute and there's an alarm going off every 5?
And doing Q1 assessments all night long.
Yeah, that's actually one of my favorite anecdotes is, oh, the patient didn't sleep all night. Like, we need to sedate them to get them to sleep. And then realizing that this patient who is getting better is convalescing. We're still doing Q1 vitals on them. It's like, well, it's going to be hard for them to sleep, right?
Or the only time your unit's able to bath patients is at 2 a.m. Yeah. Also very helpful for sleep. Okay, let's move on to choosing the right sedative. So historically, we all know the morphine midaz infusions were cranking our patients and they were really, really sedated. So let's break this down into a modern day approach with our kind of cornerstones being propofol and Precedex. And then in special populations, we're still using benzos. And lovely, lovely vitamin K. We're putting people in the K hole. So let's start off, Mitra, go-tos with propofol and Precedex. Why are they our go-tos, and when are we using them?
Yeah, thanks, Adam. The first part is I'm still waiting for the controversy. So far, this has been a very non-controversial podcast. You promised me controversy. So far, the only thing I have a problem with is you saying Manny Pacquiao doesn't hit hard. Like, I do
Rel-
not want to get hit by Manny
Relative,
Pacquiao.
yeah, yes, sir.
But yeah, so propofol and dexmedetomidine dexmedetomidine are primary sedating agents that we try to use first line nowadays. And the main reason for that is there is less association with delirium, but I think really it's that they're shorter acting. They're faster on and faster off. So, primarily, I would say that we use propofol as our first line sedating agent, not analgesic, of course, but sedating agent up front. But then, as soon as we can, we do try to switch to dexmedetomidine, primarily because it doesn't blunt the airway reflexes as much, and patients can breathe better and more likely are able to participate in spontaneous breathing trials as they're getting better. But it's primarily that both of them are short acting that is very useful versus the classic midazolam and morphine infusions. They can stay around in the system for a prolonged period of time, so patients take much longer to wake up.
Especially those infusions, morphine alone and renal failure and CRTs cranking, probably not good for most of our patients. Now, Kanji, you're the longest in the clinical tooth here. Is that benzo infusions were widely used previously? So are we throwing the baby out with the bathwater, or are there some clinical contexts where we still should be using these?
Yeah, I'm not sure if I should take offense to your first comment, but the white hairs are growing for sure. No, I couldn't agree more in terms of the benzos being harmful. I mean, we know the evidence is very clear on that. The SCCM recommendations are very clear on that. We did a quality study years ago now in the VGH ICU, which showed when we actually stopped and hard stop on benzos, that in fact there was a very, very clear correlation with reduced length of stays within the ICU. It was a clear correlation. We know that they're by and large harmful. So I couldn't agree more in terms of not using that unless it's for a specific purpose. That being said, I've seen a comeback now, and only in one sort of scenario. It's with ECMO patients. So if you are in centers that do ECMO, for some reason, obviously sedation is sometimes a bit of a challenge. We actually know that patients can be woken up like we're going through now. And historically, people are a bit more afraid and have reverted back to benzos. Now, I will put out a big alert here that benzos are terribly harmful in ECMO patients. They get sequestered by the circuit and have all the deleterious effects that we know in spades. So should definitely be stayed away in that scenario. In terms of controversy, I thought I'd add some spice here, and I wanted to know, you brought up dexmedetomidine, and since we're talking about sleep, I'm always intrigued by the Montreal protocol, right? That sort of increase dexmedetomidine at night in terms of helping, since we've mentioned sleep, that sedating effect that could be used. Does anybody use that in terms of a titrating agent to increase sort of sedation, but also restful, maybe sleep?
I have to pay homage to our clinical farm colleagues, is that you need serotonin to sleep. So giving other agents that block serotonin is probably not a good use of our pharmacologic time. So the big thing is the only true evidence in critical ill patients now of improved sleep in cardiac ICU patients is Precedex, right? So Seroquel's out, Dazodone's out, Zopiclone is a GABA agent, so it's like a benzo. So we know those agents are out now. So technically, Precedex is the only one that we're waiting for. So to elucidate on that, the Americans are studying it, Kanji. Like they're trying to figure that out. We don't have the data yet, but the last bastion has fallen. Melatonin, who it's on. I want to remind people. I know the meta-analysis says we should use it, but there's a multi-country RCT that says it actually had worse outcomes for our patients, and there was no benefit for duration of stay. And FAVA would tell us it's a REM initiator, but it can make dreams worse, so it can worsen PTSD. So to specifically answer your question, yes, Precedex would be the most evidence-based. But how many times do we show up at 6 a.m. and a heart rate is like 30 and someone's on pressors? Because we've tried Precedex, but we're maybe doing a little too much.
Yeah, or they're weaned from the vent, but they're RAS -4.
Yeah,
You can't extubate them yet.
yeah. So I think that's the caveat I would say, is that it's important. But I guess from a nursing perspective, I know nights are hard. You're doubled, sometimes you're tripled. There's codes going on. But from a nursing perspective, like things are going on at night. RTs, I get it too, Jason. What are your guys' take on Precedex for sleep versus just give them 15 azopi and then they don't bug you?
I think so. I think that propofol is really good for deep sedation because we can titrate it really easily. There is a fast onset for it. Sometimes we have the hypotension that comes with it. And then there's the feared PRIS, the propofol infusion syndrome that everybody's afraid of, especially if used for too long and at doses that are too high. In my experience using dexmedetomidine, the patients are much lighter. They're easily roused as long as we do it nicely. We don't run up to them and shake them because that sometimes results in like a really sharp wake up from them. So if we do it kind of nicely, they rouse, fairly easily. So I think that's better. And really good for the light sedation because we want them to be rousable and we want them to cooperate. And in my experience with it, that patients will wake up and they're a little bit hazy, but they'll still do what you want them to do or what you ask them to do without being super agitated. So for me, that's been my experience with Precedex and propofol.
Yeah, and for me, seeing Precedex at the bedside, I do see more bradycardia and hypertension than what is reflected in the literature. And so we often have to transition away from Precedex due to those side effects of it. And so also, it's sometimes just not strong enough of a sedation on its own. And we had to add in other agents to get the sedation we required for our patients.
I don't really have a preference for any of the sedative agents, whether we're using zopiclone or dexmedetomidine, as long as they're breathing. As long as I don't have to do the work, they do their own work, I'm happy.
Classic
Maybe,
RT, Jason. You're just like, lungs fine, good.
yeah,
Yeah,
look, I know that if I'm going to ram high pressure gas down their lungs, I'm going to cause problems. So if they want to do it themselves, awesome. Maybe if they're on a prolonged wean, I want them to be a little bit deeper so they really get a rest. So that if they're uh, really anxious and we just can't blunt that, then I want to make sure they're hammered down pretty hard so they actually rest their diaphragm when we're weaning them. But for the rest of them, as long as they're breathing, I'm quite happy. Unless, of course, they're ARDS, status asthmaticus, TBI, any of those things where we actually have to have a little bit more control of them.
nice.
I think that's actually a great point, Jason, because Adam, you asked about throwing the baby out with the bathwater, which is saying I don't fully understand because I'm not sure how exactly that works. But I
Bad
think there are
parenting.
times where you need to deeply sedate a patient, right? There's a time where RAS -5 is appropriate. Lung protective ventilation is a great example. And sometimes we saw this a lot in COVID. Patients could have a really strong drive to breathe. So they're deeply sedated with heavy doses of propofol, heavy doses of an opioid, fentanyl, and they're still not synchronous with the ventilator. They're not tolerating 6 mils per kilo. And so using an additional agent can be helpful. Of course, you could reach for paralysis, right? But sometimes there's a thought that maybe sedating rather than paralyzing will do better for the patient in the long run. And maybe that's when we go to Medaz. Or if a patient's in status epilepticus and the propofol is not working, maybe that's when we add Medaz as an adjunct too. So there are certainly indications for it. It's not that we should never use it, but it shouldn't be a primary sedating agent in the ICU, that's for sure.
Now, I couldn't be an emergency doc in my former life without mentioning ketamine. So, is ketamine useful here or in these kind of examples, or when should we bust it out, Huss?
Yeah, I think, you know what? I couldn't agree more. I have to side with you on the ketamine piece. And I think speaking to Anish's point here with regards to adjunct agents, I think it's a great agent and perhaps maybe underutilized in terms of an adjunct. We know that historically it's been shied away from ICP, but that sort of data has been debunked as far as I know. You're looking at it as a great sort of agent that provides bronchodilation, so really good in our asthmatic patients. Allows us to use less narcotics. We haven't talked about that just that much, so I'm curious to know when you add narcotics to your regimen. It's one I use so that I don't use other agents in excess, whatever that means. So I like it. You got to watch out for obviously some emergence and some reaction to the drug, but thankfully it doesn't have the hypotension effects that we see sometimes with propofol. So for me, it's actually my go-to in a lot of cases. I seem to put it on probably more than my colleagues do, perhaps, as I notice, and one that I think maybe, I'm curious to see what you guys say, we underutilize.
Yeah, I think in 2025, uh, I don't mean to be crass about this, but we've all seen that patient that's on like 45 grams of morphine equivalents a day in the community who's been contaminated with benzos and they're taking tranq. So their tolerance to our standard approach is like, you cannot sedate these human beings, right? They're uncomfortable. Maybe they got a 90% burn from their tent fire. Like they're really sick. They're in a lot of pain and you got to treat them. So I do think ketamine is the way to go. Uh, I'm a keen human being. I know like 1 to 2 milligrams per kilogram per hour of ketamine is probably a good go. 3 to 4 if you got asthma. COVID got some crazy with some anecdotes or case reports where people were using 8 and necrosing gallbladders and bladders. So probably we should remember that ketamine can cause a lot of trouble too. So good drug, but like everything else, therapeutic window is important.
I'll just add, you because you mentioned the burn patient. It's the one I have. I mean, it's a standard for me. I mean, especially with all the dressing changes and the adjunct analgesia, it's always the go-to, at least for me.
Vitamin K. Yeah. All right, so that's a good segue because we're getting into ECMO and burns and polysubstance use disorder. So let's talk about tailoring sedation to specific ICU patients. So let's break it down because really people hearing this podcast in varying tiers of units are going to wonder, well, what do I do with a neuro patient? What do I do with a burn? What do I do with a general patient? So let's start off neuro ICU. Dr. Kanji, you're the one in our neuro ICU for the province. What do you guys do?
Yeah, I think it's a pretty standard and very simple approach in this one. You just want an agent that's a quick on off. Obviously, with the neuro exam, you can't have any confounders. So really, those are the patients in which you want to avoid things like obviously benzos, absolutely, and even analgesic like narcotic type events or drugs. So really, it's propofol is your sort of go-to in the situation for a quick on off, and it also reduces ICP in some situations depending on how you tailor the drug and what you're monitoring. So that's a quick and dirty for me.
Now, Fiona and Sybil, your patient's got an EVD. It's easy for us docs to come write this RAS target EVD open, and then every time we come in the room, the ICP is 16, and you're like, no, I swear to God, they're coughing, they're bucking, they're agitated.
But Adam, like I don't know if this is what you're trying to get at, but it might be worth like discussing the point where, like, I think what you're trying to say is like we might be targeting an ideal rascal, but here the priority is something else, right?
Oh,
Oh,
100%.
like tailoring sedation to specific
Yeah,
goals.
I think it's an important point because I think that applies also for like ARDS and lung protective ventilation. Like you might want to have them light. I guess not so much when you're doing ALI, but you might want to lighten them, but you have to titrate to the ventilation that you need to achieve too, right? Sometimes.
Just since we're on the topic of ICP and TBIs, I guess the point to consider here is that often we get called for patients in transfer as well, and they're heavily sedated and they have narcotics on board. So again, I would suggest as much as possible to move to something like propofol as quickly as possible, because when they do arrive, the first thing we need is a very good neuro exam to decide disposition and management. And so that's obviously confounded depending on drugs, but almost inevitably they're heavily sedated on narcotics, or at least in the beginning, and which is reasonable. But I just consider what the outcomes are.
Yeah, it's hard to do a neuro exam and know if it's a PONS pupil or not if they're on a fentanyl infusion at a gabillion an hour for sure. All right, look how smiley Jason is. We're going to talk about lungs. Jason,
Heart and lungs.
got ARDS and these super concrete lungs. The patient is in the throes. So early on, we know that we don't want to worsen ventilator-induced lung injury. So tell me about kind of a good concoction from an RT perspective of what can improve safety for our patients.
Well, like I said before, the vent literature is pretty lousy, but we have the ARMA trial. We have the ARDSNet studies, and we know that 6 mils per kilogram is better than 12 mils per kilogram. We don't know that 6 mils per kilogram is awesome and the best, but we know it's better than 12 mils per kilogram. So we're going to ventilate them at 6 mils, and sometimes that is not achievable without completely controlling the patient. So we're also accepting higher CO2s. We're accepting lower pHs. So these guys really, really want to breathe and they want to take big breaths. And we have to protect them from that because we know that their feedback mechanisms for protecting their lungs are not working. They're taking big, big breaths and they're taking lots of them and they're damaging their own lungs because we're also following it up with positive pressure. So we want to drop them down pretty hard. There was some early studies, the Papazian stuff, showing the early paralysis was beneficial. That's kind of gone by the wayside a bit, but we want to control these guys until their PF ratio is a little bit higher, and we know that they can breathe without harming themselves too much. And then we're protecting them from. We know 48 hours on a ventilator, you're going to lose a whole lot of your, on positive pressure ventilation, you're going to lose a whole lot of your diaphragm. So we want to control them when we have to. And then when we don't have to, we want to let them breathe and let them breathe ideally at 6 mils per kilogram. But if they don't follow along, then we'll have to do something about that as well. And then somebody like a status asthmaticus patient, if we're talking about lungs and we're talking about the bad cases in lungs, we can't let them breathe when they're in a severe status asthmaticus because they can't get the last breath out. And that means that they are super, super uncomfortable, that they want to take a breath and we don't want them to because they can't get it out and they're going to blow up if we don't take care of it. And those patients really, ketamine is great, along with a whole lot of other drugs that will blunt the respiratory drive. Ideally, if you can, an anesthetic agent is great. So we started using the inhaled the Sedaconda now, I think is what it's called, and they're great. We drop them down, we hit them hard with that. We're also getting the bronchodilator effects, so they're not going to blow up because they can get the air out again. It's all good stuff, and then let them breathe when they can, so that we don't have the diaphragm atrophy. We don't have poor distribution of ventilation. We don't damage the lungs with villi. We don't do all the bad stuff that a ventilator does, and let the ventilator do the good stuff that a ventilator does.
You're saying an air blower that just turns on and off isn't useful for patients? We're talking about Jason. So a few things to unpack there because it's great. We're if the throes of ARDS. I know the whole point of the podcast is trying to move towards lighter sedation, but that's just to say, just like our ICP and our neuro patients, if you're in the throes of acute illness, hit them hard. And to follow up on what Anish said earlier, is that we learned in COVID, young people with lung injuries that want to breathe really want to breathe, and it's hard to stop them from breathing. So we're going to be using multimodal sedation and analgesia with multiple agents while they're in that acute illness. And then every day, like Jason said, trying to evaluate, have we met exit criteria for acute lung injury and lung protective ventilation? Have we met exit criteria? Have we met exit criteria? And when we do, transition over to a lighter sedation strategy. But the Sedaconda that you brought up too, Jason, some people listening to this might not know, is that why do we have to use a scavenger for sevoflurane? Why can't we just use an anesthesia vent setup? I think we all agree here is anesthesia vents suck. They're really hard to ventilate patients unless you have a lot of software. So most centers use the Draeger, and it's not a ventilator that's designed for an acutely sick patient. So not easy to use. So what you're referring to is something to scavenge the sevoflurane by using an ICU circuit, correct?
That and the fact that you don't have rebreathing in the circuit because there's emerging evidence about all the bad stuff that happens with rebreathing anesthetic agents.
So in this setup, what you're describing is using a general anesthetic, but in the ICU, like you're
Correct.
physically in the ICU, right?
So it's basically the Sedacon is basically an HME that has a little sponge on it, and you drip sevoflurane or isoflurane onto this little sponge, and then you use any ICU ventilator to blow that into the patient and then let it come back out again. It's got a little bit of charcoal on this HME, which somehow bounces the anesthetic back into the patient. So you end up rebreathing the anesthetic without the downside of the CO2 absorber.
Yeah, it's a really cool setup.
For me, I just put them on ECMO.
Yeah, I was gonna say I'm waiting for Kanji. I'm waiting for Kanji. He did it.
The man has a hammer.
Yeah.
We'll get there. We'll absolutely get there to ECMO.
Yeah.
Work.
But another point, just to highlight off of what Jason said, is that transition that you're describing, Adam, of going from deep sedation to light sedation, you're checking every day. Well, that transition only really can happen quickly if you're on short-acting agents. If you're on long-acting agents that sequester into the fatty tissue and then get redistribute even after you've stopped them, that patient might be comatose and not be able to transition to pressure support for days, maybe even weeks.
Can I ask a question? Because you described it so well in terms of your approach, both Adam and Anish. I'd be curious then, how do we actually titrate that sedation? I know there's awakening. I don't know if we want to be too controversial, or do we target RAS or do both? So what's your approach? And I know there's some harm potentially with one, but maybe we're just not using it the way it should be. I don't know.
I'm not so sure this is controversial, but we'll see. We'll see if Adam makes it spicy. But I think most of the practice is transitioning to like RAS titration, RAS targeting. So if you target a RAS of 0 and are slowly starting to wake the patient up and seeing how they are waking, and then during that time determining if you can safely do that. Sometimes you can't, right? Sometimes the patient starts waking up aggressively, tries to self-extubate. Well, then they're no longer RAS of 0. You have to sedate them more deeply and then maybe titrate slowly, maybe try to transition to another agent. I think the concern that I would have with spontaneous awakening trials, I think the concern that people have is that if you just turn the sedation off, they could wake up and self-extubate with a bang, right?
Yeah, I can see Sybil and Fiona are like, yeah.
Yeah, there are a couple of centers that have gone to halving the sedation instead of stopping it fully to kind of alleviate that fear a little bit, and seems to be working so far. So I'm curious what you think about that, like rather than just stopping the sedation fully, just halving it.
Yeah, I think like if you think about international approaches, so there's a spectrum. So I hate to crap on the Americans because they're doing a lot of work. They were deep sedation, and then they taught us about SATs, and now they're actually just moving towards Precedex for everybody. That's their big ethos. North Europeans, especially Sweden, Denmark, and Finland, this group, we've talked about it, is that their nursing ratios are a dream. So they got 2 nurses to 1 critical care plus HCAs plus assistants. So that's somebody that can probably undergo no sedation. So the no sedata and that literature base is where they have very little infusions at all, and they're using PRNs only to sedate or for analgesia. And then I think Canada, we're in the middle. Is we have to understand the literature basis for sure, but then we have to understand our human resource issues too. Is that it is really hard to continually titrate to a RAS score when you haven't been able to get to that patient in 3 hours because you've been with 2 other patients. And it also, in that context, is really hard just to turn off all the drugs at once if you have nobody to back you up and put the tube back in. So I think that's where we were going to talk about controversies later. We're here now is how do we roll that out in BC? Because we know in some of our units, it's such a wide spectrum where they might have 1 ICU nurse and 3 patients covering that unit for the night. And then other ones are still short, but have more friends around, right? In a 60-bed unit. So really, I'd like everyone's take on this is what should we do? Because I think we need a new approach. I think we need to merge reducing sedation mechanistically every day because everyone's busy and that needs to happen every day. but I don't think it needs to be turn everything off and pray they aren't 10% of the people that extubate themselves. But I'm open to ideas.
Yeah, I would circle back to what Anish said about like setting that RAS goal and slowly getting there and then reevaluating your clinical goals as you go along and then like changing as you go. So slowly chipping away at sedation, make sure we're meeting clinical goals, try to get to a zero. But again, looking at our human resource shortage, knowing that there has to be some sort of safety component in there. But then I also concerned with our restraint usage going up on our patients because of our human resource issues. And so that has to be a consideration too about the long-term impacts on patients on restraint usage and the PTSD they suffer from that too. So that's another consideration about how we manage sedation.
Yeah, that's a good point, Fiona, about the restraints for sure, because we know that that increases the risk of delirium and PTSD afterwards. You know, remembering we listen to patient partners and their stories about their experience in ICU and how they actually remember things that happened, and it's very different from reality. But the way that they perceive it is exactly their reality, and so they're left with that impression as they transition out of the ICU and into the hospital and then into homes where their families are caring for them and you know, having to hear about the terrible things that happen to them. So I think that's a really good point that you brought up about the restraint use.
Yeah, but like guys, let's be honest. We took decades of watching the Saw movies. Can you imagine like just being hit by a bus and then waking up restrained? You got tubes in places there shouldn't be tubes, including a fecal management system. And then every time you move, like the restraints get tied down more. So it's not a nice scenario to be in for sure. But I guess what I'm trying to unfold though is that again, our listeners are in many different types of units. So yes, if you have a culture and you're used to just targeting RAS to zero, let's chip away at it. And a nurse that's been working for 15 years is going to be able to get there with the PRNs and the goal. But what if we're with a mixed level experience and mixed units and in resources where maybe the physician's so busy they're not round until 4 o'clock? So then how do we make sure our patients are when they're ready, how do we make sure that we get them to a lighter sedation? I genuinely would like to know.
I'm going to just jump in and say, Anish, I totally agree with your approach. And I actually have to say that I was on the bandwagon of it's got to be RAS and RAS only. But I was humbled in speaking to individuals who work in those units where they're, you know, maybe a bit more community or resourcing is definitely a challenge. And mindset and culture is not there, right, as well. So people need to be brought along. So though the efforts have been made to make or set a RAS goal, the frustration was they never were able to achieve it because, to be honest, it's primarily what I heard physician based, right? There's reluctance actually to do that. And if they had set that goal, then getting to that goal was a problem. So how do we protocolize that approach, like you said, Adam, to achieving that goal? I don't think one can be done without the other. I like the idea of a safe SAT. What does that mean? Is it in half? But it can't be forgotten that the target is we still have to get to the RAS. So not to forget about why we're doing the sedation. My 2 cents.
Yeah, Huss, I think a follow-up point to that, though, is that it needs to be discussed daily. Rounds like the interdisciplinary discussion about that when we think of nurses that are starting in critical care that are, you know, very new to that area. They've learned during the pandemic where all patients were kind of snowed, and now we're kind of coming out of that and changing the practices a little bit. It needs to be an interdisciplinary discussion and approach to that, and in some of our smaller centers that's not happening. And so when we have SAT protocols where safety screening criteria is clearly laid out, I think it's important also to encourage the nurses and RTs around even the SBTs to be able to work to their full scope of practice and look at those screening criteria and follow it, but also have that discussion with the physicians during rounds as well. I don't think this is a this or that, it's a this and that and the interdisciplinary conversation about it.
Yeah,
Unit
Sybil,
culture, like you said.
I think that's a great point because you know the barriers to lightning sedation are probably multiple different barriers, right? And so the approach to solving the problem will depend on what the barrier is. So if the issue is it's one nurse to 3 vented patients, which seems unsafe, then the priority should be safety, right? The ideal is a RAS of 0, perhaps, but you have to keep the patient safe. That's always the priority. So the goal may have to change in that setting. Versus if the problem is that the person who can manage the airway, if there's a self-extubation, is not available in the morning, then that's something that needs to be discussed with the team. Then what's the plan for lightening the sedation for that patient? So I think that's a great point. The interdisciplinary discussion to discuss the barriers, discuss the target, then discuss the barriers, and then the solutions for them is probably the way to go.
Nice. And for listeners, like, we do want to highlight, we get the breadth. Like, we're admitting so many different patients to ICUs. The heterogeneity is tough here, and we don't want to lose that context. But our approach to someone who just was a GHB overdosing, everything can get turned off and they can be extubated, is very different than someone who's been ventilated for 21 days, is trached, and we're waiting for the midazolam to wear off. That was turned off last week, right? So there's big variance in there, and we want to get it. I think the things I heard too that make this very difficult, because we can't just speak to the literature base, is that workforce and patient safety issues that Anish, you really eloquently put it that way, is that if you are in a unit and there's not enough help, is safety first, is that we're not going to like the bundle evidence-based RASA 0 and you got to sweat all night trying to titrate your propofol by 0.4 every 15 minutes, because that's practically not going to happen.
Yeah, and I think speaking to like how novice a lot of the nursing staff is now too, and how we can support novice practitioners and nurses in their practice by giving them standardized tools, mentorship and support to help bring them up to a place where they understand like that what the safety features are and how they can go about doing this. But that's challenging if there's not experienced staff on the unit to actually mentor them. And so how do we, as a province, come together to build tools for that, knowing that that may not be available in all the sites?
You took it right out of my mind. That's what I was thinking. It's like when you watch a gangster PCC or a CNL or a CNE, just go tell a nurse who's 1 year out of BCIT course, be like, oh no, just turn it off. Or like, no, we're just going to do this. Like, there's so much experience in that little reassurance to them, and a clinical practice. And I totally agree, is that how do we build a tool to build on that experience so that we can bring it to all centers in the province, right?
Yeah. And just a reminder to the staff to keep their eyes on the ball. Our whole goal is to eventually get that tube out and get them out of the ICU. And if we keep sedating them, that's not going to happen. So just remember that. If we keep them safe, that's great. If we keep them safe for 6 months on a ventilator, that's bad.
Yeah. But they're safe, Jason. They're safe the whole time. Yeah.
But Jason, I think you also highlight that sometimes it's helpful for our RT listeners to potentially communicate to the nurses that they can't switch over to pressure support and they think it's sedation because of sedation, right? Because that is probably usually on the radar, but maybe it's not because there's other priorities, especially with the workload that's being required these days for bedside nurses. It's useful for the RTs to comment on that, kind of delaying that transition to pressure support.
Oh, 100%. We've got to get the clinicians comfortable with talking to one another and communicating, which is another huge issue in the ICUs.
I just wanted to say, Jason, sometimes I remember at the bedside, I'd hear from the RTs, oh, the patient needs to be sedated. Well, going back to what we talked about at the beginning, is it pain or is it sedation, right? And I think we have to really look at that separately and treat separately, like what exactly are we treating here, and go back to that. So it is important for the RTs and RNs to be able to have that discussion before these things are done, for sure. But like, eye on the ball, what are we trying to treat here?
I was just going to say, point to your SBTs, which I don't think we've actually focused on that much, but maybe we should. And we know that SATs and SBTs have a huge effect on getting the tube out. And there's just been an inability or lack there of doing SBTs because patients are so deeply sedated. And there's a spot fallen by the wayside. This usual norm practice does not occur any longer. And I think it's a big miss.
It's shocking because, again, it's one of the few things we actually know will make a difference in a patient's care and length of stay is doing an SBT and taking the tube out. And anytime we miss that, we're bad and wrong, and we did the wrong thing.
But to make everyone feel good, the world is bad and wrong. It's not just DC context. It's that the global literature just showed like everybody across the board right now, except the Northern Europeans apparently, are struggling with deeper sedation for their patients, a longer stays on mechanical ventilation than prior to COVID. So again, it's a classic ICU. Blame COVID. Damn COVID. But yeah. But that's the context we live and work in now. The context of how do we balance SAT, like a new type of SAT with the literature that just shows that it should be a RASA minus 2 to 0, right? So
Well, I hate
Like to-
SATs. I hate them because if the patient is on an SBT, on an SAT, and they're tachypnic or hypertensive or their heart rate is 150, how do I know that that's an issue of them failing the SBT, or how do I know that they're just mad that we just dropped their sedation?
Yeah,
And
I think Jason, to your point, for the next podcast, I assume we'll probably maybe do SBTs. I don't know, but that's a point to highlight because the number of times someone's tachypnic because they're delirious, and we're like, oh, if they failed we can't extubate them, just drives me crazy because it's like, well, is keeping the tube in going to treat their delirium? Like,
Yeah, and is it pain, Anish? Like we've sedated them and now we've turned off the sedation, but we've sedated them so long that maybe we don't realize that they're in pain, and so we shut it off, and all of a sudden they're aware of their pain and they're pissed, right? And then they fail their SBT, like you say, Jason.
Oh, I was just going to say, I think that speaks to the inexperience of our people at the bedside, because I think that
Yeah.
historically people could tease that apart, but now I'm finding they
Yeah.
cannot tease that apart. So
I think
so
that's
we've got strict protocols. When they hit this
exactly.
criteria,
Yeah.
stop the SBT, unless there's an order saying you ignore it. So the RTs are going to follow the protocols because the whole system is set up that way. If you think that it's going to be an issue with their agitation, with their pain, whatever, and you don't care about their rest rate, say that. Say, don't care about the rest rate, do the SBT anyways. Follow the regular criteria. If their CO2, well, if their blood pressure drops to 40 on 20, we'll maybe stop then. If they start looking horrible, maybe stop then. But if they just look like they're delirious, let them go.
But like Jason, what I would say is the context of this podcast, like we're aiming to help those people that aren't really used to waking people up all the time. Like in those units that would typically just shift those difficult weans to you in Fraser, because they say, "Oh, we tried to wean them 3 times. They're impossible to wean. They're coming to the Columbia now." But really, what we're trying to arm them with is an approach to try to approach an SAT and an SBT in a non-controversial patient. But yeah, like your fibrotic patient who has horrible dead space and they've stroked and now are delirious. That I think that's not really what we're trying to core educate with this podcast, right? That's a nuance and really what makes our job interesting. I know it's maybe not the sexiest thing for us, but that's why we all trained in critical care and we specialize in it, right?
yeah, but I think Jason brings up a good point. Like, if there's a protocol in place, probably most RTs will or maybe have to follow that protocol.
Oh, I
So
see your point.
it has to be
Okay.
explicitly stated if you want to.
Yeah.
I think that's a good start if there's a protocol anyways, right? The point like at VGH, we're not even doing SBTs. Like, and I don't know how many of our patients. So it just shows you how, people got so busy that like, I really like your point, Adam, in terms of steering the ship or maybe going back to basics or what the state of ICU is right now, that we've forgotten about the things that make the big difference. And so bringing us back to the core of what we know what actually works, which is SATs and eventually SBTs.
Do you need to do SBTs for ECMO patients?
No, but they do for the transplants that spent sedated all night, right? Yeah.
We use we studied we do full ventilation trials on these guys. Same idea, brought from SBTs to know in the same way you can get them or decannulated earlier. Anyways.
All right, guys, we're nearing the end. Thanks for sticking with us for a longer format here, but I'd like to consolidate because if we spend any time on this podcast, these are the things I want you guys to remember. So, starting with Mitra, what are our top takeaways on ICU sedation?
For me, I'd say number one is try to lighten sedation as much as possible. Try to target a RAScal of 0 as much as possible when safe. And in doing that, probably prefer to use short-acting agents like propofol and dexmedetomidine. And with that in mind, with prioritizing sedation in mind, remember that agitation is not the same as pain. So if a patient has pain, treat it with an analgesic first, and then titrate your sedation accordingly to the RAScal.
Propofol, no make femur fracture better. Got you. Yeah. Kanji, what do you think?
I agree, surprisingly, with Anish on this one. I think I'd just take it a next step further and just say tailor the sedation to the patient. So recognizing that your neuro patient needs that deep sedation sometimes. Your ARDS certainly does, but that's not all your patients. That your general ICU patients do better with a RAS goal of 0. We know that, and that to achieve that, we need to do daily awakenings, wake ups, whatever you want to call it, spontaneous awakening trials in a safe manner. But that titration is to a RAS goal. So I like what Sybil said, not if and that, maybe both. You probably put it more eloquently than I, but I think both should be considered.
Just turn it down. You don't have to turn it off. Just
Yeah,
every day, turn it down. Okay.
just try.
Yeah.
Like just challenge it a little bit and see. You know, a lot of times we challenge things and we don't necessarily know if it's going to work or not, and we're like, "Yay, look at that! It worked." So I think we should at least try it.
Fiona?
To remember that introducing benzos to your patients is a high delirium risk, and so to avoid continuous benzo infusions whenever possible, and to only use them if absolutely clinically indicated.
Jason?
If you need to, just like Anish was saying, if you have to give them a lot, if you have to drop them down hard so you control them, do it. But if you don't, then it is way easier to manage a patient if they're breathing spontaneously, if they're doing their own thing, and you can get the tube out, and then you have less patients to look after because they're off of your patient load. So the lower the sedation, the better for the RTs.
Now, Sybil, I'm going to give you the opportunity to leave us with any important message that you like, because you're to be blamed for this podcast in the first.
Fantastic. I think what we've talked about here at the end is just to really consider the context that we have patients in, the settings that we're treating them in, the resources that are there, and also the patient-specific needs, like tailoring it specifically to what the patient needs, and coming back to that, treat the pain first. You know, we don't want to forget that sedation, like we talked about, propofol is really quick acting, but is that the appropriate choice in that situation, right? Like, let's try and treat the pain first and then see if it's the sedation problem, and then go that way. And at the end of the day, the interdisciplinary conversation during rounds, the documentation of the RAS target and the RAS scores and pain scores, having those documented allows us to see whether any action that we're making with the patients is actually making a difference before and after, right? Like, is what we're doing making a difference? And at the end of the day, I think the nurses and the RTs and the physicians, that's what we want to do. That's why we're in this work, right? We want to make a difference for the patients. And without that documentation, we can't tell if they're doing that. And so, I know I'm maybe nursing leader here, piping on documentation, but at the same time, it does make a difference. And if we can report back to the direct care staff about the impact, the positive impact their efforts are making to them, it's going to reinforce and help change that culture to less sedation, get the patients, wake them up, get them off of the vent, walk them, and get them out of
Change that
ICU.
culture.
That should be our ultimate goal.
Yeah,
Culture, yeah.
I agreed. Look, Anish is smiling so much because you talked about data and measurement. All right, guys. I just want to thank everybody. So remember, Dr. Anish, Mitra, Dr. Hussein, Kanji, Sybil, Fiona, Jason. Thank you guys so much for joining us on this podcast. And hopefully we'll have more.
Like and subscribe.